Dear doctors, blessed Ramadan. My name is Grace Estefan, and I'm here to welcome you all to our anemia session entitled Holistic Approach to Diagnose Anemia Complex Blood Disorder, powered by Omnia Health. This session underlines how clinical laboratories offer a broad range of diagnostic tests across disciplines that help reduce the impact of anemia, being a disease so prevalent and serious, and improve efficiencies in the care of anemic patients. During the webinar, please make sure to add your questions to the Q&A box and fill in a short evaluation poll at the end of the session. Also, please explore the documents attached on the webinar console. Let us welcome our esteemed speaker, namely Dr. Hanan Al-Wazzan. Dr. Hanan is a consultant in hematology and the head of the hematology unit at Adan Hospital in Kuwait. She is as well the chairperson of the Kuwait Board of Hematology, a graduate in clinical hematology from the Imperial College. Dr. Hanan is a member of the British Society of Hematology and of the European Society of Hematology. Dr. Hanan has several publications and research articles under the hematology disorders in various disease patterns. The floor is yours, Dr. Hanan.
Thank you, Grace, for this nice introduction, and thank you for joining the webinar. I'll take you through the holistic approach to diagnose anemia. I will be taking you through the clinical background, the current anemia workup, what are the other tests available for anemia, and what Beckman Coulter can provide in the diagnosis of anemia. Before going to more diagnostic tests, we'd like to define the anemia. Anemia defined physiologically by the decreased capacity of the red cells to transport iron. Numerically, this is the reduction of the red cells mass or reduce in the hemoglobin concentration. For a male, it is less than 13 grams per deciliter, and a female less than 12 grams per deciliter, according to the WHO. Or it is less than reference range assigned for age and sex match group, if you are talking about children or any other group. Why we are talking about anemia today? Anemia is defined by the WHO as a world health problem. It affects globally. It impairs the quality of life. It has potential health complication. It can be life-threatening. It has both social and economic effects. It affects a lot of individuals around the world, with 25% of the global inhabitants has been affected by anemia. We approximate about 2 million individuals. In a study adopted by the WHO and published in 2008, where data show the prevalence of anemia from 1990, data from 1993 to 2005 has shown that anemia to affect globally all around the world, and the most vulnerable populations is the young children and pregnant female and people with serious and chronic disease. The highest prevalence is in preschool children and the lowest in male, with the prevalence of anemia in Africa for preschool children is 67%, and in Europe 21%. The prevalence of anemia in a pregnant female in Africa is 57%, and in Europe 25%. However, as the population is growing, anemia prevalence increase and rose rapidly, with prevalence more than 20% in people who are above the age of 85. And as the life expectancy continues to be increasing, it is going to be a real health problem in the future. In addition, anemia affects surgical patients in a negative way. It can increase the post-operative morbidity and mortality. Why anemia is important? Because people with anemia presents with a large variety of symptoms, and many symptoms are shared with other diseases. In addition, the underlying diseases can also cause similar symptoms, so it is difficult to diagnose the patient with symptoms. They can have cardiovascular symptoms like the dyspnea, palpitation, systolic murmur. Sometimes they present with heart failure. They can have the CNS symptoms like fatigue, depression, decreased cognitive function. They can have genital symptoms like decreased libido or menstrual disturbances. They can also have the vascular symptoms and vascular symptoms and the gastrointestinal symptoms. Also, anemia has complex etiology, and it is sometimes difficult to diagnose the underlying cause, or they have more than one cause. In a study published in Blood in 2004, and on the population of USA, they found that 35% of anemia is due to unexplained or combined cause, while 24% is due to anemia of chronic disease, 17% is due to iron deficiency anemia, 14% due vitamin deficiency, and the rest is due to renal impairment. Most of the anemias are not explained, and the root cause remains unknown, reflecting the difficulty good diagnosis of anemia. This statistics, of course, is a USA statistics, and these proportions, especially in the developing countries where the anemia of iron deficiency or vitamin deficiency are more frequent. The complexity of anemia and the challenges the clinicians face reaching a diagnosis. So a wealth of information should be compiled from a variety of sources, especially from the laboratory testing. So we start diagnosis of anemia by extensive medical history, family history, physical examination, in addition to laboratory investigation. We start with the first of all diagnosis of anemia by measuring the hemoglobin and the hematocrit, then a classification of anemia measuring the white cells and the platelets can also and help in diagnosis that this is either a bone marrow disease or isolated anemia. Reticulocytes count, its derived parameter like immature reticulocytes factor or mean reticulocytes volume or reticulocytes number is also helpful. In addition, we have chemical parameters including iron, serum iron, transferrin iron binding capacity, percentage of transferrin saturation to serum iron multiplied by the 100 divided by TIBC, and in addition to the testing for the serum folate, B12 and serum ferritin and soluble transferrin receptors. Inflammatory markers, which is not available in all the labs, including the IL-6, can be helpful. CRP also helpful in the diagnosis of inflammation, in addition to the hemolytic markers of bilirubin, conjugated and unconjugated, and the LDH. So in approaching a patient with anemia, we start with the diagnosis of the presence of anemia, then classification of anemia, and then we can classify anemia as a normocytic normochromic or macrocytic hypochromic, or it is the macrocytic anemia. In case of normocytic and macrocytic anemia, reticulocytes count should be done, so that patients with normocytic normochromic anemia with low or low normal reticulocytes count give us idea. It could be a differential diagnosis, either renal insufficiency, bone marrow infiltrations, anemia, chronic illness, MDS, or combined deficiency. If it is normocytic normochromic anemia with with increased reticulocytes count, it could be acute hemorrhage, or it could be hemolytic anemias, or also it could be combined anemias. And if it is macrocytic, the macrocytic hypochromic anemia, then the high reticulocytes count can be due to hemorrhage or partially treated megaloblastic anemia, or it could be hemolysis. If it is reticulocytes normal or low, either megaloblastic or non-megaloblastic. Megaloblastic could be B12 or folate. Non-megaloblastic could be liver disease, high alcoholism, hypothyroidism, or MDS. Microcytic hypochromic anemia, we do serum ferritin. If it is low, it is iron deficiency anemia, and if it is high, it is iron deficiency. It is anemia of chronic disease, or combined iron deficiency anemia and anemia of chronic illness. So in approaching the diagnosis of anemia, we use the CBC counters for Russell for definition of anemia, classification of anemia, and by measuring the Russell count, white blood cells, platelet, hemoglobin, and hematocrit. Then we do additional Russell indices like MCV, MCH, MCHC, and the RDW. Then additional tests should be added, which is in cases of normocytic normochromic or macrocytic anemia with the reticulocyte count. And then we can classify anemia as macrocytic hypochromic or normocytic normochromic, or macrocytic hypochromic, with the different level of reticulocytes count, in addition of performing the blood film for the patient, which has a major diagnostic impact. Then for the after the defining if it is macrocytic and hypochromic, if we suspect iron deficiency anemia, we would use the serum iron and transferrin saturation and TIBC in order to differentiate between anemia of iron deficiency or anemia of chronic disease. We can do also CRP for the anemia of chronic disease. If it is normocytic normochromic with the Higher triglycerides, then we suspect there is hemolysis and blood loss. If it is with low or normal, could be chronic anemia of chronic disease or anemia of renal impairment. So we'll do the CRP or cystatin C and creatinine for renal disease. If it is macrostic anemia with low triglycerides count, it could be B12 and folate deficiency, so we'll do the homocysteine level. If we success B12 and folate deficiency, if it is no, it could be alcoholism or it could be cirrhosis. We'll do liver enzymes or metabolic symptoms syndrome, or it could be due to MDS. In addition, we can use immunoassay parameters in helping diagnosis. If it is microcystic hypochromic, we can do the ferritin level, serum transferrin. If anemia of chronic disease, we can do in some lab interleukin 6. In normocystic normochromic anemia, we can do erythropoietin. If it is anemia of renal disease, we can do serum ferritin and serum transferrin receptor. In case of macrocystic anemia, we can measure the B12 and folate in the red cells on the serum, and also we can measure the intrinsic factor antibodies. Diagnosis anemia of disorders of iron metabolism. It can be either anemia of iron deficiency, where there is reduced circulating and stored iron, or anemia of a chronic disease, where is functional iron deficiency, or combined anemia, which is iron deficiency anemia and anemia of a chronic disease. This is the hemostasis of the iron in the body, where the plasma iron is maintained in a relatively narrow range from 10 to 30 microgram. Iron circulate in the plasma bound to serum transferrin, which maintains iron in soluble form, which is a major route of entry of iron into the cells through the transferrin receptors, and it limits the generation of toxic radicals. The homeostasis system responds to signals from the pathway that consumes iron, which is the bone marrow erythropoiesis, and signals to the cells that supply iron to the blood. It increases absorption of iron through the duodenal enterocytes, which absorbs from 1 to 2 milligram per day of dietary iron, and from macrophages, which internally recycles 20 to 25 milligrams of iron per day from senescent erythrocytes. Although the body regulates the process of iron absorption, iron storage, iron recycling, there is no process of iron excretion, so the excess of iron will be stored in the macrophages or in the liver or in other tissues. So the metabolism of iron is a dynamic process where the iron is absorbed from the GI and transported into the erythroid bone marrow, where it is necessary for the production of the red cells. And the diagnosis is assessment of the iron status in the body depending on the measuring of the 3-bol, which is the major functional bol measured by the hemoglobin concentration, and the storage bol measured by serum ferritin, and the transient bol measured by the total iron binding capacity. The metabolism of iron is a dynamic process, and the iron is transported through by the transferrin from the transit bol to the functional bol. This occurs through the interactions of the transferrin with its receptors on the surface of the erythroid cells. So the uptake of iron is by erythroid cells is mediated through the cell transferrin receptor. In the serum, there is a truncated fragment of the transferrin receptors which called serum transferrin receptors. And the possible configuration is that it is two transferrin receptor monomers binding, each one bind one transferrin molecule. So the level of the 80% of transferrin receptors is on the erythroid precursor cells. The amount the transferrin receptor expressed on the cells depends on the iron concentration in the cytoplasm. When the iron in the cell is reduced, there is increased synthesis of transferrin receptors, and if the iron is saturated in the cytoplasm, there is decrease in the transferrin receptor expression. So therefore, the level of the serum transferrin receptor reflects the cell's need for iron, but also it reflects, but its needs of iron, but also it reflects the rate of erythropoiesis and erythroid precursors mass. In iron deficient anemia, normal situations, there is normal stores for iron, normal functional pool, and normal transit pool. When the ferritin start to decrease, when the iron-restricted erythropoiesis, the serum transferrin receptors will be expressed more, and the serum transferrin receptor index is very high from the start of the iron-depleted erythropoiesis, and it is more increase in iron-deficient anemia. In anemia of chronic disorders, there is increased expression of interleukin, and interleukin increase the expression of hepcidin. Hepcidin will decrease the absorption of iron from the enterocytes and release of the iron from the macrophages, resulting in functional iron deficiency. In functional iron deficiency, sometimes patients, they have iron deficiency. In these situations, diagnosis may be difficult, and the ferritin is always high in either in acute or chronic situations, so it is not useful marker for diagnosis of iron deficiency in case of chronic disease. However, the serum transferrin receptors start to increase whenever there is iron-restricted erythropoiesis, and the iron transferrin index is also increased. In a study done at 4 sites and published in 1997 showed, including 145 patients with the anemia of chronic disease, anemia of iron deficiency, or combined anemia, that showed that the data showed the three figures. The first figure showed that the serum ferritin can differentiate between anemia of chronic disease and anemia of iron deficiency, but cannot differentiate the combined anemia. However, in the serum transferrin receptors, the serum ferritin is the level is very low in anemia of chronic disease, and it is high in iron deficiency anemia, but it also cannot differentiate between the iron deficiency anemia or combined deficiency. But it also differentiates between anemia of chronic disease alone or anemia combined with the iron deficiency with anemia of chronic disease. Using the serum transferrin index will clearly differentiate the three types of anemia, where the anemia of iron deficiency is very high and the anemia of chronic illness is very low, and the combined deficiency is in between. Using the receiver operator characteristics graph to assess the diagnostic performance of the serum transferrin receptor index, it shows, using a cutoff value of 14, has increased the sensitivity and specificity of the test of the serum transferrin receptors and can be used and clinical utility for establishing the anemia of iron deficiency in case of combined of chronic inflammation, since serum transferrin receptor is not affected by the not acute phase reactant and not affected by inflammation. So the other uses, clinical uses of the serum transferrin receptor is the evaluation of erythropoiesis to define the need for transfusion in cases of diminished erythropoietic activity and as an aplastic anemia or post-chemotherapy. In case of increase, to define the increase of erythropoietic activity following the development of the serum transfer receptor assay, clinical study was conducted to confirm the clinical utility of the serum transfer receptors to differentiate of iron deficiency anemia and the anemia of chronic disease. But also to determine the optimum, the clinical decision level of the serum transfer receptors. The study was carried out in 4 different centers in Europe and in the USA, where 145 patients were recruited with the anemia of chronic illness, iron deficiency anemia, and combined anemia. The clinical interest is that described in 1997 by the publisher Bononin, who published in the Blood. The first figure shows that the ferritin can differentiate between iron deficiency anemia and the anemia, and cannot differentiate between the first figure shows that the ferritin can be elevated in cases of combined of iron deficiency anemia with the anemia of chronic disease, and it is difficult to diagnose anemia of iron in these patients because of ferritin is acute phase reactant. So the determining serum transferrin receptors, and which is not affected by inflammation, and it will be normal in the anemia of chronic disease isolated, and it will be high in the iron deficiency anemia and iron deficiency combined with anemia of chronic disease. Also, using the transferrin receptor index has the same value. However, improve the sensitivity and specificity, where the receiver-observer effectiveness characteristics curve shows that the area under the graph of the serum transferrin receptor at the cutoff point of 14 has similar sensitivity to the serum transferrin receptor, but higher specificity. Additional clinical interest of the serum transferrin receptor is related to the ability of the serum transferrin receptor to predict the erythropoiesis and the rate of erythropoiesis. And a recent publication had suggested a role of the serum transferrin in the erythropoiesis and the optimal transfusion schedule. For example, for those patients who had diminished erythropoiesis, like aplastic anemia or post-chemotherapy, for post-transplant engraftment, assessment of the erythropoiesis and engraftment, the preoperative iron erythropoiesis assessment in elderly who had very limited the bone marrow hemobiotic cells. So putting these all together, we can come a diagnosis of iron deficiency is by measuring the MCV, MCH, then using the serum ferritin by immunoassay. If the serum ferritin is low and the serum iron is low and the transferrin saturation is low, it is diagnosis of iron deficiency anemia. However, if the serum ferritin is normal or high, you cannot differentiate between it is anemia, isolated anemia of chronic illness, or it is combined with the iron deficiency. So using the serum transferrin receptor index will differentiate. It will be high in the presence of iron deficiency and normal or low in the cases of isolated anemia of chronic inflammation. Also, use of CRP may be helpful. It is increase in inflammation, but will not differentiate between the combined anemia or anemia of chronic illness. So with the unique expertise of the hematology and immunodiagnostic, the Beckman Coulter had providing new parameters for diagnosis of anemia, like the immunoassay for the interleukin-6 for anemia of chronic disease, erythropoietin level for the anemia of cancer or anemia of renal impairment, the intrinsic factor antibodies for the diagnosis of B12 deficiency, and for soluble the transferrin receptor for diagnosis of iron deficiency anemia or combined anemia. In addition, there are hematological parameters, which can be derived from the routine parameters, and it will be within the routine CBC or the CBC differential mode to flag the abnormal cells like the microcytic anemia factors for detection of microcytic rest cells, and the rest cell size factor, which is detection of the abnormal size rest cells, low hemoglobin density percentage for detecting the hypochromic cells, mean spherocytic cell volume, detection of spherocytes, and the mean neutrophils and mean neutrophil volume and mean monocyte volume for detecting of megaloblastic anemia, in addition to the mean scatter and conductivity for dysplastic cells. The mean anemia factor parameter is the inexpensive laboratory parameter. It is derived from the hemoglobin and the MCV. It is MCV multiplied by hemoglobin divided by 100. It is indirect marker of the iron-restricted erythropoiesis. It combines both the size and the hemoglobin content. It is not affected by the acute phase reactant and reflect the state of erythropoiesis. It can detect the early iron-restricted erythropoiesis. So in patients, many patients have latent iron deficiency, and it is unrecognized problem, and the prevalence in the latent iron deficiency in female in their gestational age is about 15%. And this will not affect the hemoglobin, may affect the MCV, but MCV can be normal. So using the MAF can help in the diagnosis, and first you identify the presence of anemia, then the anemia could be either normocytic, and if it is severe, it's likely normocytic if it is very early, iron deficiency, or it could be macrocytic in case of more severe iron depleted erythropoiesis. Then you will do the MAF, which is macrocytic anemia factor. If the MAF is low, then it is either isolated anemia or combined anemia. So you will do the serum ferritin. If it is low, it could be the serum only isolated anemia, and if it is high, maybe it is anemia of chronic combined anemia. And if the MAF is normal, then there is no macrocytic cells, so it is anemia of chronic disease. In addition, there is the red size factor. Red size factor is also a new parameter, and it's provided by Beckman Coulter. It joins the volume of erythrocytes with the volume of reticulocytes, the square root of the MCV multiplied by the MRV. And the utility of this parameter is for assessment to help also differentiate in iron deficiency anemia, which is possible, give us a possibility of iron deficiency anemia, and allow for further investigation. So in anemia of macrocytic anemia, we will do the red cell factor. If the red cell factor is low, means that the size is low, so we'll do the iron metabolism with serum ferritin and the serum transferrin receptor index or receptor. This is iron deficiency anemia. And if the RSF is high and the ferritin is normal or high, with high ILS, low serum transferrin receptor, then it is anemia of chronic inflammation or anemia of renal impairment. The RF is the recent publication has demonstrated the detection of the restricted erythropoiesis, which has good sensitivity and specificity with the hemoglobin content of the reticulocytes if they use the cutoff volume of 88. Anemia of renal failure. The anemia of renal disease or impairment is related to decrease of production of red blood cells, and the physiological situation. The erythropoietin is the primary regulator of the blood production. It stimulates the bone marrow for erythropoiesis, and there is a sensor in the kidney where there is any hypoxia. It translates into the switching on the erythropoietin production, and the level in physiological situations, there is a normal erythropoietin level with the expected and over the observed expected ratio is constant between 0.8 and 1.2. And if the hemoglobin drop less than 12, there will be increase in the erythropoietin. And when the OP or the observed to the predicted ratio is decreased, there is a defective production of erythropoietin. And if it is increased, there is increased production of erythropoietin as in early pregnancy, high altitude, in cases of hemolytic anemia or secondary polycythemia. Low erythropoietin or low O to OP ratio will be in case of chronic kidney disease, chronic inflammations, and in cases of polycythemia rubra vera and cancer. So anemia of renal impairment, usually we have normocytic normochromic anemia. It could be macrocytic anemia. So normocytic normochromic, then we have any normocytic normochromic anemia, you have to evaluate reticulocytes. If reticulocytes count is high, It is you rule out hemolytic anemia. If the erythrocyte of the reticulocyte is normal or reduced, it could be anemia of chronic inflammation or anemia of renal impairment. So if the erythropoietin is low, you will measure the creatinine and the blood urea nitrogen or cystatin, and also it could be anemia of inflammation. If the erythropoietin is high, it could be bone marrow infiltration, or it could be the MDS, or it could be anemia of chronic disease. There is also a hematological parameter called low hemoglobin density provided by Beckman Coulter. It is derived parameter from the mean hemoglobin concentration using a mathematical transformation. And it is a reliable parameter for detection of iron deficiency in the presence of inflammation. So in anemia of renal failure, we are using more than one parameter. So usually anemia is a microcytic, anemia of microcytic hypochromic, or anemia of normocytic normochromic. You will do the we will do the low hemoglobin density percentage. If it is high, it means more hypochromic cells, so we'll do the rest size factor. And if the rest size factor is low, then we'll do the iron profile, including ferritin and serum transferrin receptor. And if it is serum transferrin receptor is high, it is anemia of iron deficiency. If the low hemoglobin density is low and the cell size factor is normal or high, it could be anemia of chronic kidney disease or anemia of chronic inflammation. And the combination of the low hemoglobin density and rest cell factor provide additional information of anemia of iron deficiency in case of renal disease. Renal disease where it could be adding a diagnostic significant. In both situations, the serum ferritin, serum transferrin index, or serum transferrin and iron will be helped to confirm the diagnosis. Also, the LDH was demonstrated to have LHD has been shown to have a good clinical performance, comparing it to the percentage of hypochromic cells. And it has the only advantage that it is stable and can be measured after 24 hours if the sample has been stored at 20 at room temperatures, and after 48 hours if the sample has been stored at in the fridge. Coming to different types of anemias, also the anemia of vitamin deficiency, B12 and folate deficiency are also common cause of anemias, and there are many causes of B12 deficiency, including decreased absorption, increased demand, or defective transportations of the vitamins. And the symptoms of anemia is similar to general symptoms of anemia. In addition to the specific symptoms of the paresthesia of both hands and feet, ataxia of severe deficiency and maybe unreversible, in addition to a diminished perception of vibration and position sense. Why B12 is important in the anemia? B12 is not a component of the hemoglobin. However, it is used in the DNA synthesis of cells during erythrobiosis. It is involved in the converting of the deoxyuridylate into deoxythymidylate, which needs the methylene tetrahydrofolate. Methylene tetrahydrofolate is it is the product of reduction of the of methylation of the methyl tetrahydrofolate to demethylation to tetrahydrofolate in the presence of B12. So in the normal situations, the B12 is derived from meat, fish and cheese. Vitamin is liberated from the animal proteins and from in the gastric juice. It's combined to the transport protein intrinsic factor produced by the gastric parietal cells. And for transporting of the B12 through the stomach and through the intestine and be absorbed in the ileum, where the B12 intrinsic factors receptors is there to be neutralized and transported in the bloodstream through transcopolamine 1, 2, and 3. So the intrinsic factor antibodies, they are autoantibodies, which is prevent the binding of B12 to intrinsic factor, resulting in the decreased absorptions or malabsorption of B12, and they call it pernicious anemia. The intrinsic factors antibody are present in 70%, 50 to 70% of pernicious anemia patients, and rarely caused by other conditions. There are two types of antibody. Type 1, which present in the 70%, which is blocking antibody, block the B12 binding site to the intrinsic factors. And type 2 antibodies, which is present in 30 to 40%, which block the site on the enterocyte for the binding of the intrinsic factor B12 complex. And these antibodies are does not exist, it does not present alone. They have to be combined with type 1. So the intrinsic factors antibody presence will confirm the diagnosis of pernicious anemia. However, their absence does not rule out pernicious anemia. The diagnostic, the antibody have very high specificity and sensitivity, and the presence of the antibodies and the presence of B12 will confirm the diagnosis of pernicious anemia. So anemia of B12, the deficiency, the usually anemia is macrocytic and hypochromic. Then we have to, if it is macrocytic hypochromic, we can do B12 and to diagnose anemia, or first we start with reticulocytes to rule out hemolysis, then B12 if it is low. Then it is we'll do the antibody if it is present as pernicious anemia. If it is negative, in the past we were doing shrink test, but not any more available. Still, we can diagnose maybe by endoscopy with the biopsy of the atrophy of the gastric atrophy. And if it is high, it is unlikely to be because of the B12 deficiency. It could be other causes of macrocytic anemia. Combining all these together, so usually anemia of vitamin are macrocytic and hypochromic. Evaluation of reticulocytes to rule out hemorrhage and hemolysis or partially treated deficiency. Normal or reduced reticulocytes in case of macrocytic anemia trigger the evaluation of folate, rested folate, and B12. And if they are normal, additional chemical tests for liver disease, a thyroid function test required, as hypothyroidism may result in the also in the macroscopic anemia. MDS can be a cause, and when B12 is low, then performing intrinsic factor immune assay help to diagnose pernicious anemia. For diagnosis of folate deficiency, the serum folate is modified by recent dietary intake. Low serum folate without body depletion occurs with the recent alcohol abuse and will not differentiate between negative folate balance and tissue folate deficiency. However, cell folate, it is direct measure of the tissue folate store, and cell folate decrease after 4 months of negative balance. Low serum folate and normal cell folate indicative of negative balance. However, the low cell folate indicative of significantly depletion of the folate store. Do we have any parameter which can suggest the megaloblastic or the deficiency of B12 and folate without the measuring the vitamins? Yes, and with the Beckman Coulter, they have the mean neutrophil volume and mean monocyte volume in a study carried and showed that patients who have they have increase in the mean neutrophil and monocyte volume in both B12 and folate deficiency. So the anemia management with the solution of the Beckman Coulter combination for hematology, clinical chemistry, immunodiagnostic, and automated system. It is a comprehensive panel with all hematology but needed parameters for diagnosis of anemia, chemical parameters, and immuno assays also. It is innovative the solutions with the good and rapid test results. And I came to the end of my talk. And if you have any questions, please, you can. Thank you.
Thank you a lot, Dr. Hanan, for this interesting presentation. Indeed, we have several questions that are written, so I will start with the first question. With regards to CBC result of the patient, for example, a baby more than 1 year old, all factors in CBC are normal except hemoglobin and hematocrit, which are both high. What might be the factors that affect the results to a high level?
This is a physiological polycythemia in a baby. The factors I spoke about were not studied in the newborn. So the significance of these factors, the new innovative parameters I spoke about, is only diagnosis of anemia. So the CBC is expected to have high hemoglobin and hematocrit in a newborn baby. I think this is the answer for her question.
The second question is, for us in poor resource settings with near absence of auto-analyzers, how can one appreciate and take on this issue within the limit of manual FBC and maybe film reading?
Actually, in this setting, if you don't have a CBC counter and the advanced level, I think you just stick to the classification by the size. And if you don't have the sizing and you just have traditional method of the macrocytosis by morphology, I think this is the best. Also, this is very standard method to see the blood film for hypochromia and macrocytosis and compare it to the sizing of the the nucleus of the small lymphocytes, which can be comparing the size of the red cells to the size of the nucleus of the small lymphocyte would be a good way to compare.
A third question, is there any relationship of anemia with platelet count?
Yes, it is known that anemia, especially iron deficiency anemia or anemia because of bleeding, they have reactive thrombocytosis. It is well known, and actually when the patient comes with thrombocytosis to the clinic, we check for his CBC and MCV and MCH and REW and chemical parameters to rule out underlying iron deficiency.
Another question, can you explain about the reticulated hemoglobin or RETHE to evaluate iron deficiency anemia and other anemia and bleeding?
Reticulated hemoglobin?
Reticulated hemoglobin.
Yeah, reticulated hemoglobin means the hemoglobin inside the reticulocytes. It is increased in cases of increases in case of the effective erythrobiosis will be increased in the case of good hemobiosis, which is indicator that there is a good underlying bone marrow and there is no dysfunction. And if it is low, it means there is a deficiency of the iron, so there is reduction in the amount of hemoglobin the new cells are produced, and it is also a good parameter.
Is there any advantage of having an analyzer with hemoglobin and ferritin in point of care, or the assessment of anemia should be done with an integral panel of tests?
Actually, if you are saying that you are depending on where you're putting the point of care according to the need of the population, you have to study the population you are going to put it. If it is in the casualty, there is no need. It may have a value in the prenatal clinic where there is prevalence of anemia. However, with the CBC parameters and addition of the new parameters, I think you can safely say the patient had iron deficiency. Personally, I don't rarely measure ferritin. I just use the CBC parameters to diagnose iron deficiency anemia with very low CAB MCH and high REW. And this is enough in case to diagnose, especially presence of anemia and the risk factors. So I don't find a value unless in the prenatal clinic, there is a facility for parenteral iron. You want to give the patient as fast as possible. Yes, it has a value.
One last question, because we are running out of time. The microcytic anemia factor, MAF, and the LDH percentage are both parameters for iron deficiency. If we want to choose one of these two that has better iron deficiency correlation, which one should that be?
I think if it gives me the choice, I'll go with the RSF. I'd like to have that instead of LHD. Both parameters are for iron deficiency, but the MAF have better correlation.
And though I said last question, but because this question is correlated, what is the value of RSF?
To diagnose iron deficiency, iron deficient erythrobiosis.
Okay.
I think we are.
Thanks a lot to all attendees. Please don't forget to answer poll questions. And if you need to ask more questions, please put them in the Q&A. We will get back to you later. Thanks a lot, Dr. Hanan. It was really an honor to have you present on anemia, and really like the feedback from the attendees was great. We thank you, and we wish all those who are celebrating Ramadan a happy and blessed Ramadan, and happy Easter as well to all those who are celebrating Easter. Thank you, and looking forward to more educational activities.
Thank you. Masa.
Thank you.
Masa.